of our women's health lectures for the year. Thank you so much, Rebecca, for organizing this and advertising and making it truly collaborative between Midland Memorial Hospital and Midland College and our Texas Tech Health Sciences Center. I'm very pleased to introduce Dr. Gary Ventolini as our first speaker for the year in our Women's Health Series. Dr. Ventolini recently relocated from Ohio, where he served as the chair of obstetrics and gynecology. He is the new Texas Tech Health Sciences Center Regional Dean, and he's also a professor in the Department of Obstetrics and Gynecology here. He is board certified both in obstetrics and gynecology and family medicine. Dr. Ventolini has authored extensive publications in peer-reviewed journals and medical textbooks. Among his many, many accomplishments, he is a member of the editorial board of the Journal of Gynecologic Surgery, as well as the Journal of Genital System and Disorders. Dr. Ventolini, thank you so much for offering to speak to our audience members about the important topic of sexual dysfunction.
Okay, now I think we're okay. Thank you very much for being here. Thanks a lot for the invitation to the Midland College, and thanks a lot for Dr. Cho for this opportunity. So today we're going to talk about sex at lunchtime.
Sorry, I thought it was this.
Our objectives today are going to report some facts and statistics regarding sexual dysfunction. We're going to review some factors that impact the sexual responsiveness, analyze the lifespan experience on the woman's sexuality, and explain what are the diagnoses and the treatments for the different sexual dysfunctions. I don't have any conflict of interest except that I was here because my mom and dad one day decided to have sex. The sexual response cycle is a model that describes the physiological response that takes place during sexual activity. And one of the first models was put in place by William Masters and Virginia Johnson many years ago. They sent a survey of how people were having sex, and from there they deducted that the sexual response cycle has 4 phases: excitement, plateau, orgasm, and resolution. And it was very easily described on the desired excitement, plateau, orgasm, and resolution a few years after. But then we start finding out something very interesting. Men and women brain works differently. Really? Sure. What happened here is we have men which have just excitement, plateau, orgasm, and that can be from a few seconds to a few minutes. But then we have observed that women can have 3 different patterns. One of the patterns is you can have the excitement, the plateau, never get an orgasm, and get the resolution. Other women, instead, they have excitement, plateau, and they're orgasmic, and they can be orgasmic many times. Or the other group has the excitement, the plateau, orgasm, and then a very fast resolution.
Oh.
And then, on the early 2000s, Basin came back and said, it's not as easy. It's not as easy because basically what we have to think is, what is the impact of the emotional intimacy? You can have emotional intimacy, being cuddling yourself, kissing, caressing, and then all of a sudden you have the sexual stimuli if everything is right. If the light is right, if the right music, if the candle, if the guy has brought the diamond, maybe, even better, you may be aroused. The arousal and desire, emotional and physical satisfaction without even having an orgasm. So why is that? Because we said the facts are that sexual dysfunction is very common in the United States. Around 15% of all the women has some kind of sexual dysfunction. It's across the lifespan. But the important thing is, we're going to talk about satisfaction. Sexual relationship satisfaction is not exclusively determined by sexual function. So what is the sexual organ of humans? Brain. Very good. So you can see, according to the ages, what the sexual function comes is mostly around the perimenopausal period. And some people have been, this is due to hormonal changes, this is due to other changes. The reality is that the only big study that we have regarding Rosen in '93, looking at patients ages 18 to 73, 28% were non-sexually active, and they were still happy around. Other has anxiety or inhibition during sex. Those were around 40%. Other patient had pain during sexual intercourse and was close to 20%. And almost 60% has significant orgasm difficulties. So the factors that impact sexual responsiveness are the physical, the psychological, and the relationship. On the physical factors, we have the vascular and neuroendocrine system. To have sex, you have to be healthy. If you have any ailment that comes from, you won't be able to do it. If you are depressed or you have any psychological component, you are not going to be ready to have sex. Medications can increase or decrease desire and the response, and we're going to see which one and what do they do. Nerve damage, of course. If you have a spinal cord injury, then the lower part of your body is not going to feel anything, and it's going to be very difficult to have sex or sexual satisfaction. And some recreational drugs. If you drink too much alcohol, or you are in cocaine, or in other substances, then you're not going to be able to have to be ready to have sex. Psychological factors, if we have acute or chronic stress, gender or sexual identity problems or confusion, sex role satisfaction, sexual knowledge and the attitude. Okay, we're going to have sex. You did it before? No, neither do I. Did you read something? No. So where did you learn? Oh, I heard Dr. Oprah or Dr. Susan Sommer. You're going to be in big trouble. And also depends on your body image. Negative body image is going to cause that. Oh, I think that we are missing. We're missing some of my slides. Sorry, we're missing some of the slides, and then I think yes. No. Let's go there. That's why I asked him if he was that. Sorry, this one. This is mine. That one. I need to put it on this. Sorry for I give the talk to different people. Some are physicians, some are specialists, some are lay people. So I think we have one that was not the right one for you. Okay, yes, so let's quick. Oh! I was busy myself. So we're talking about the women's brain and men's brain. Why are they different? Have you asked that question, why they are different? They're different because when we are inside the womb of our mother, the uterus, at 16 weeks of age, we have a discharge of testosterone in our brain that kills almost all the neurons except two. One keeps us alive, and the other one, everybody knows where it is. Instead, you see, women are more complex. And that's not just regarding sexuality. One time my wife asked me to go to Gap and buy a pair of pants. I was thinking just a pair of pants. I like cotton ones and what color was, and I went to Gap and I buy the pants. Then the next day she has to go and do the same. And you can see. I spent 6 pesos and $33. She spent 3 hours, 26 minutes, and $876. So that's a problem. So I asked one of my researchers on neurology, can you tell me how can they show what is the complexity of the women's brain? And she sent me these pictures. I said, oh my gosh. So we talk about that, and the prevalence, and what happened here regarding the physical part and psychological factors is this one. How about if you have a wrong body image? It says $100 for speeding and $250 for misleading the public. I'm sexy. So let's look at the relationship factors. Child or adult abuse, physical or sexual, is very important. Even the perception. I have had some patients that when they were very small, they were 3 or 4 years of age, they saw their mom and dad having sex. And if you're a 3 or 4 year old and you see a couple having sex, it looks like they are beating each other. So that creates in their subconscious some blockage that is very difficult to, so when they come to the situation that they have to have sex, then they're going to remember, not consciously, but subconsciously. Attachment issues, attachment issues, previous sexual partners and experiences. You had a sexual experience that was very bad the first time because nobody knew what they were doing, or you see the difference. The men can be ready in 2 seconds. Women needs a lot of time. One of the psychologists defined men just need a place to have sex. Women need a reason. So that's why. Current relationship. What is the quality and commitment of the relationship? And what is the degree of sexual preferences? Do we have a similar sexual preference? Do we have different sexual preference? Because you can come to this situation. In this relationship, it's going to be very difficult to figure out how they're going to have sex anymore. I'm pregnant, and says I'm sterile. Or if you have the same attitude against men that Maxine has. Men are always whining about how we're suffocating them. Personally, I think if you can hear them whining, you are not pressing hard enough the pillow. Let's look at the anatomy of the vulva. Do you all have to look at your vulva? Because it's amazing. When I see patients, sometimes I ask them, have you ever taken a mirror and see your vulva? No, so how are you going to be able to know what's going on? To be able to have sex? So we have here the clitoris hood, the labia minora. This is the urethra meatus, and this is the entrance of the vagina. Women are better equipped than men. Men has one tube from which urine and sperm comes out. Instead, women has two different orifices for that. You're not going to believe that I have seen during the last 10 years at least 5 patients who has come to me, and they have been previously seen by obstetricians, gynecologists, family physicians, that they didn't have a clitoris. Why? 3 of them has been circumcised in Africa. They still do those kind of things. And 2 of them have their clitoris completely covered because they have a condition called lichen sclerosis. So I don't blame you, you haven't seen your own vulva and vagina, but I encourage you to do it because you have to know if it looks something like that, it's okay. If it doesn't look something like that, find out why. The lifespan experiences and women's sexuality is different on the menstrual cycle. And here we're not going to discuss that hormones has a lot of things to do with that. If you look at other mammals, the other mammals are very good at representing themselves when they're ready to ovulate, therefore when they are ready to have sex and have a probe. In women that completely disappear. Why is that? We don't know. Something that has to do with evolution, because if you look back on the years, what happened initially when we were cavemen was there was no reason, and this is one of the theories, there was no reason for men to be close to women the whole time, especially to protect the baby, that it takes 1 year before they start walking. All the other mammals, they have their babies and they start walking right away. So how do you protect a woman to bring food and be able to protect them for as long as 1 year? You have to make this man who has just 2 neurons ready to have sex. And how do you do that? You have, during the menstrual cycle, you'll see that the breasts are always there. It's not like in other species that if they are not ready on the estrum, the breasts just shrink, they're not visible. And that's one of the theories what happened. Pregnancy, lactation, and postpartum. Some patients, this is the rule of 3. They're pregnant, they're more eager to have sex. Others, it doesn't change. Others, they don't want to see the man anymore. It's just normal ways of behaving. During lactation is the same. Some patient wants to lactate and still have sex, others no. Or in the postpartum period. We always encourage them to wait at least 6 weeks so they have all the physiology back. Menopause and hormone replacement therapy, just to mention, because we are all young and healthy here. Hysterectomy and aging also can play a role, but that will be the topic of a different lecture. On the drugs, you can see I'm not going to touch all of them, but you can see that some medications like adrenergic blockers or anticholinergics, increased prolactin or clonidine, antipsychotic, antidepressant can knock out completely the desire of having sex. The serotonin reuptake inhibitor that we use a lot for depression or anxiety depression, they are very, very tough. At least 40% of them blocks completely the sexuality. The pharmaceuticals are saying, no, it's just 10 to 20%, and you know how they are. They don't usually tell you the truth because they have to sell medication. Isn't it cute? So what is a sexual dysfunction? According to the DSM-5 4, the definition is a sexual dysfunction is characterized as any sexual complaint or problem resulting from disorders of desire, arousal, orgasm, or sexual pain, causing marked distress or interpersonal difficulty. So if you have some of these, but you don't bother about that, you don't have a sexual dysfunction. Okay? That has to cause marked distress or make the interpersonal relationship very difficult. Let's see which ones are there. First, we're going to talk about sexual desire disorders. Second, sexual arousal disorders. Third, the orgasmic disorders. Fourth, sexual pain disorders. Fifth, sexual dysfunction, not otherwise specified. Or sixth, sexual satisfaction. So let's look at the desire disorders. There's one called hypoactive sexual disorder, desire disorder. What is that? It's persistent or recurrent absence or deficit of sexual fantasies and desire for sexual activity. Instead, the sexual aversion disorder is persistent or recurrent aversion to and avoidance of genital contact with the sexual partner. So you see, in one you said, I don't want to have anything to do with sex. The other one is, I rather have a pizza now than having sex. How common are they? The hypoactive sexual desire disorder is very common. 30 to 50% in women. It can usually be generalized or lifelong. We have to make sure that these patients don't have endocrine problems or illness, that they don't allow them to have the desire, or they are in long-term medications that are causing that problem. And keep in mind always depression. What is the treatment for sexual desire disorders? We can use in certain patients, especially the ones who had the ovaries out, or they have chemotherapy, or they have lost their uterus, testosterone in an aqueous solution every 2 weeks, or a patch that we use for men that can be used in also women in different conditions. In selected cases, we can use antidepressant because if the patient is depressed, then we have to treat the depression. Yoimbin in some studies has been shown that has something to do about that. And dopamine agonist also can be used for desire. Of course, the best way of dealing with desire is, unfortunately, one of the studies that the Swedish put in place. And it's a randomized controlled trial, and the conclusion for them was change partner. Over there it's easy, but not so easy all over the rest of the world. Regarding the treatment of sexual desire disorders, remember, no current norms for sexual desire in different age groups. I have had patients who think about sex every minute of the day, others that they think about sex once a day, others once a week, others once a month, and others every time a pope dies. And anything in between. So there's not the norm. Whatever is your desire about having sex, that's your way of handling it. Desire and behavioral frequencies remain stable. Lesbians stop having sex while maintaining a good relationship. And individual or couple therapy is one of the most difficult sexual disorders to treat with psychotherapy. So on these ones, how I don't want to have sex, how can I have sex? Is one of the most difficult questions to answer. We have to rule out that there's no illness involved, that there's no depression. And then from there, we have to give them some techniques. And one of the most utilized by the sexual therapist is, do you remember when you first meet him or her? Yes, how was it? Oh, it was nice. We went to dinner one night and she brought me a flower, and then she had ready a diamond or a pearl. Women have different. And it was very nice. Okay, why you don't try to do the same? What are you talking about? Yes. Get together outside, get to a nice place, possible the same place that you were there. You don't have to have a pearl or a diamond this time, something like that, and see what happens. Sexual aversion disorders are much rare. Those are the patients who don't want to have sex at all. And this usually happens associated with low desire, with vaginismus, which is a condition in which they close the vagina as hard as they can, sometimes the legs. When they come to the doctor, they don't want you to be examined. They have a lot of pain when they try to have sex. This patient has, or we have to rule out that they have a history of sexual abuse, or history of physical abuse, anxiety, or obsessive-compulsive disorders. I have had patients that the only way that I can have sex is I have to wash my hand 10 times, and then I have to wash his penis, and then I have to make sure that I put some spray, that there's no others around, and things like that. Okay, if you find the partner, and the partner agrees, happy both. The treatment of sexual aversion disorders is a psychological intervention that has to be individual or the couple. Learning cognitive therapy behavior techniques, desensitization, let me touch you first the knee, and then I touch you the leg, and oh yes, I know where I'm going to be after that. Working through past issues of abuse, they have to recognize, they have to have healed about that. Usually in these patients, I usually tell them, it's not what happened before, it's what is your attitude regarding that. That happened, you were very unfortunate, you didn't cause that problem, that usually the males who are doing that to you, but please look ahead. You have to heal that. You have to recognize that that happened. You cannot do anything about that except going ahead and think positively. And the psychological intervention is going to help you. But I'm not crazy. You are not crazy. When you go to the psychiatrist, it's not because you are crazy. They are specifically trained to deal with these issues. Focus on the conflict areas. There are usually issues of control. Focus on specific aversion of phobic dimensions. And I usually don't give anxiolytics. I like anti-anxiety medications. I like also to be given, those to be given by psychiatrists. Sometimes are very, very difficult to treat. That's why we need the help from them. Sexual arousal disorders are uncommon in women unless they are in menopause, or they have pain, or they don't have orgasms. Lack of lubrication in this case is one of the causes. So I usually ask the patient, oh, I don't have any desire. Okay, you don't have any desire, but he or she starts. Oh yes, then I keep going. That's normal. You don't have to have the desire then to get aroused. But when you are aroused and everything comes back to be okay, that's normal. The treatment will be ruling out any physical causes, scar tissue, using creams or gels. I don't like KY gel or any bactericidal gel for sexual intercourse, because they kill the lactobacillus. The lactobacillus are the normal bacteria that we have in the vagina that protects us against everything else. So if you're going to use any gel, you use Riplens or Astroglide. I don't have any stocks in any of these companies. or estrogen replacement when the patients are menopausal. The orgasmic disorders, those are very common. 10% of women have never had an orgasm, and they're happy. 50% of women has situational or intermittent orgasm. They're having sex, but then all of a sudden they are interrupted, or the baby's crying, or somebody else called, or whatever happened, and then they cannot have an orgasm. Rarely there's a physical cause. And why rarely is a physical cause? Because usually the stimulation of the clitoris that is long enough is going to get you having an orgasm. Some women instead, they have better or different orgasms when they have a vaginal orgasm. They have to have penetration of some kind in order to have an orgasm. But any of the two is normal. Antidepressants, if the patients are depressed. Why do I put so much emphasis on depression? Because we have a lot of patients who are depressed and they don't recognize that. So when they come to me because they are anorgasmic, and then what happens is you give a screening for depression and they fail. I don't like to see the future, I'm very sad, I don't like anything that I was doing before, I have had some thoughts of hurting myself. Then you know that we have to rule out the depression. There are some medications that cause orgasm delay, like the monoamine oxidase, the tricyclic medication, or some of the medications that we use for the psychiatric problems. So they try to get to the orgasm, but they can't. They try to get to the orgasm, and they can't. Psychological and interpersonal factors. They don't like themselves, they're ashamed, they don't want to show their vagina or their vulva, they're unpleasant. They were unpleasant on early sexual experiences, or you have an ineffective sexual technique or sexual partner. Male partners or orgasmic women are distressed themselves and feel irresponsible. You know how it's still prevalent that, if I didn't get her an orgasm, I don't feel like a man. So then what do you do to make them feel like a man? You fake the orgasm. So you provide support, but not feel responsible. That usually happens. Caution, alligator mating season, is attack, fake orgasm. How do we treat orgasmic disorder? Masturbation. It's not a bad word, masturbation. Why? Because if you are able to get an orgasm yourself, you're going to be able to get it in a relationship. If you don't love yourself, you're not going to be able to love anybody else. I know that during all our early ages, since we are in high school, everybody was trying to hide that masturbation. I have had patients who, when they come with these problems, you ask a few questions, there are some questionnaires that they fill up, and what they happen, every time they were masturbating themselves, they were punishing themselves. What kind of relationship are you going to have if that happens? Traditional sex therapy techniques are effective 75%. These are effective 88 to 90%. Both individuals, group, of couple therapy. First you're going to do it yourself, then you ask your partner to do it. There are books, tapes. Heyman Topiccolo has one of the best ones. It's called Becoming Orgasmic by Simon F. Schuster. I don't have anything to do even with this book. It was published in 1998. And sometimes it's a long process. You need 15 to 20 therapeutic sessions. You cannot have an orgasm right away. Oh yes, I read the book and then I'm going to have an orgasm. But it helps. Sexual pain disorders, dyspareunia. So you have recurrent genital pain before, during, or after intercourse. Has the most variable presentation. 7% of sexual complaints are related to pain during sexual intercourse. We have to have a careful physical exam to rule out that there's an injury, that there's the presence of endometriosis. Endometriosis is a condition in which when you have your menstrual period, part of the blood goes out as a menstrual period, part goes through the tube and goes inside the belly. If your mechanism of defense are okay, nothing will happen. If there's pieces that go there and your mechanism of defense are not good, those when they land inside your belly cause pain. Unusual skin sensitivity. Some patients are extremely sensitive there. Trigonitis, which is a condition in which you have the base of the bladder that is very tender. And not all the physicians recognize that. So every time you're going to have sex, you're going to have pain. Or a condition that we call vulvodynia, that we have pain in the vulvar area. We don't know what causes. We know that the orifice of the skin glands and the Bartholin glands are very tender, or the fourchette. Psychological factors, traumatic sexual events, or relationship distress can also help to do that. How do we treat the dyspareunia? After we have ruled out all the psychotherapy for behavioral patterns and emotions, discuss the need to rely on non-coital sexual expression, ways to control her focus and relax, protocol for vulvodynia. The sexual disorders, we look at the vaginismus. Vaginismus is every time there's a tempting and sexual intercourse is impossible. Recurrent involuntary spasm on the outer third of the vagina that causes embarrassment and frustration and is approximately 3% of the sexual complaints. It's less common in lesbian couples. The relationship of distress or desire for pregnancy sometimes can cause that. Rule out physical signs and rule out psychological factors. Strong sexual inhibition, sexual trauma, or unexpressed negative feelings toward males, phobias, or pain, tension, pain, and every time I'm going to have it, I have that cycle, so you have to break that out. What is the treatment for vaginismus? After you have ruled out that there's any psychiatry component or sexual abuse, molestation that was not resolved, then series or graduated dilators coupled with relaxation. So you start from very, very tiny dilators that looks like a toothpick until you go to the big dilator. There's another book written by Values, which is very good if you still find it. When a woman's body says no to sex, by Penguin, I don't have anything to do with this book either. Gradual involvement of the partner with dilators after you are able to do it by yourself, finger, penis, and reliance on the woman's guidance to control the pace and duration of the sexual activity. When that happens, one of my first advice is you have to be on top of your partner because you have to control the penetration. Otherwise, you'll be at his or her mercy. Screening. So how do we find out that there's a sexual problem? Do you have any current sexual concerns or problem? Then the most important is, does the problem bothers you enough that you will like to do something about it? If you have a problem but it doesn't bother you, then you don't have sexual dysfunction. But if it's bothering you, yes. So that's what happens when you don't have a healthy relationship. Okay, you can have another spin, the only cause is your birthday. No sex, and you're just like. So, we reported the facts and statistics of sexual dysfunction. We review one of the factors impacting sexual responsiveness. We analyze the lifespan of experiences of women's sexuality, and we explain diagnosis and treatment of sexual dysfunction in women. Now, I'm ready for questions. I don't know any of you besides Dr. Chop, so anybody can ask any kind of question. Yes?
I don't have a question, but I want you to go back to the conclusion.
Was the joke, because sometimes you have somebody understand it right away, some other that takes longer time, some other the next day says, wow, now I get it. Any questions? Yes.
You said it, I missed it. What percentage of menopausal women experience a decrease in sex drive or loss of sex
Depends. Depends on how they achieve the menopause. The ones who went to the natural menopause, that means they didn't have any surgery, they didn't have any radiation therapy, they didn't have any chemotherapy. Then usually those are the ones that is more natural transition, and they complain less about sexual. Instead, if all of a sudden you remove the ovaries or you start giving medication to her, then those are the ones that are going to cause that. Then depends on the relationship of the couple. You know, we always talk about everything is a communication problem. Also, the relation is a communication problem. If you lose that relationship that you have in many years because you have been in a stable relationship for a long time, and then all of a sudden you become menopause, and then you have your partner who has problems, then of course you're going to have more of that happen. So that's why. When they lose one of the two neurons, yes. Just so. Of course, there are some situations in which testicular cancer, they have to remove the testicles, medication, the same depression, impotence, then they can lose the Any other question? Yes?
Is in general, we think that it's more related to women because of the more complexity of their brain.
If you want to put it in that way. Why? If you look at the evolution from the reproductive point of view, how much do you need the male to perpetuate the species? Not too much. And that happens in all the spectrum. So you need just one male, and then you can have a lot of females, and then the species perpetuates. That's why when they have cows, they have just one bull, because one bull is able to. So that's the way of the relation. Most of what? We don't know. We don't know. We think that part of the lesbian couples is they are not as, and those comes from some observational studies. They are not as traumatic when they have sex together. They are not. Their sexual relationship is not as aggressive. It's not as the males in general, they want to have the penetration because otherwise they don't get happy. That doesn't happen on lesbian couples. It happens less. They know each other, their body, so that also helps. That's the reason we think. Yes?
Why is it so often that you notice that women that have a child first, 9 times out of 10, you'll hear that person say that their intimacy level decreases as they child. Is it always related to the inconvenience that the time having a child, or is this for intimacy that is hormonally related?
Again, it's very complex because how do you expect that a woman who has a small kid and then has to take care of 2 or 3 people at the same time is going to have the same desire and time to get the arousal and the mind to be open, and if they're lactating or is very close to the delivery, then the prolactin level is going to be high. The prolactin level inhibits the sexual relationship, so that then the lubrication changes. When you still have progesterone, you're going to have less lubrication in the vagina. So that's why we observe that. That's a very interesting question. There are very few physicians who devote their life to deal with sexual problems and all the vaginal conditions. Why? Because you don't produce money. It takes half an hour to talk to a patient. You don't send any patients to the hospital for surgery. You don't do too many labs. And unfortunately, unless the healthcare system changes, we're going to be faced with that reality. In medical school, they try to reduce the time for everything. The residency training programs are also squeezed. With more knowledge, somebody determines that that's not too much important. And you see, even on the research, why we have 6 or 7 different medications for male dysfunction, and we don't have anything for female dysfunction. We did some studies with Procter & Gamble regarding a patch, testosterone patch specifically for women. Great results. They never put it on the market. Any other question? They are free. We don't charge anything for them. Okay. Thank you very much.